A 22-year-old female presents to an outpatient clinic with a 48-hour history of classic burning on urination, dysuria. She reports increased urinary frequency and intense urgency. She denies fever, afebrile, and flank pain, which helps the clinician rule out upper UTI pyelonephritis and focus on acute cystitis. A midstream urine sample is collected for quantitative analysis and sent for immediate processing. Microscopic suspect profile, gram-positive spherical cocci, approximately 1 micrometer in diameter. The arrangement, characteristically arranged in grape-like clusters. The why. This arrangement results from cell division occurring in multiple planes where the daughter cells remain attached. Visual staining. They stain a deep violet or purple due to the thick peptidoglycan layer of the gram-positive cell wall. Growth requirements, non-fastidious and non-motile. They thrive aerobically at 37 degrees Celsius. Blood agar appearance produces opaque, white, non-hemolytic colonies, also known as gamma hemolysis. SLED agar, cysteine lactose electrolyte deficient, while often used for urine cultures to inhibit protease swarming, S. saprophyticus will typically appear as small, yellow or white colonies, depending on the strain. Identification note. Unlike S. aureus, these colonies lack the characteristic golden yellow pigmentation. Catalase test, positive. Immediate effervescence, bubbles, with H2O2. This identifies it as a Staphylococcus and rules out Streptococcus species. Coagulase test, negative. No clot formation in plasma. This places it in the coagulase-negative Staphylococci, co-NS group, and rules out the more virulent S. aureus. Novobiocin sensitivity, the hallmark. Resistance to a 5 microgram novobiocin disc is the definitive diagnostic feature used to distinguish it from other common co-NS, like S. saprophyticus. Epidermidis, which is sensitive. Its pathogenicity is driven by a 160 kJ kDa hemagglutinin adhesin protein. Mechanism of action. This specialized surface protein acts as a molecular anchor, allowing the bacteria to effectively adhere to the uroepithelial cells of the human urinary tract. Survival strategy. This adherence aggressively resists the natural flushing action of urine, facilitating colonization. It is a leading cause of community-acquired urinary tract infection, UTI, specifically acute cystitis. The demographic almost exclusively targets sexually active young women. The rare side. While typically a localized pathogen, it can occasionally cause more invasive systemic infections in immunocompromised individuals. Gold standard. Quantitative urine culture. CAS concept of significance. Symptomatic patients, a colony count of 0-10 cubic CFU milliliter is considered significant. Asymptomatic patients, a count of 0-10 cubic CFU milliliter is required for a diagnosis of significant bacteriuria. Specimen logistics. Urine should be processed within 2 hours. If a delay is expected, it must be refrigerated or preserved with boric acid for up to 24 hours. The therapeutic antidotes. Uncomplicated UTIs are generally managed with oral therapy. Preferred agents. Quinolones, e.g. norfloxacin, nitrofurantoin, cephalosporins. The shield, intrinsically resistant to novobiocin, used as a diagnostic marker. Group defenses. Like most gram-positive bacteria, it possesses intrinsic resistance to aztreonam and polymyxins, such as colistin. Which biochemical reaction is the key feature that distinguishes S. saprophyticus from S. epidermidis? Answer C. Resistance to a 5 microgram novobiocin disc. In a symptomatic 22-year-old female, what is the minimum colony count required for S. saprophyticus? Saprophyticus, to be considered a significant UTI pathogen. Answer B. 10 cubed CFU milliliter. What is the specific molecular weight of the adhesin protein that serves as the primary virulence factor for S. saprophyticus? Answer C. 160 teledata.